Good evening, class. We're going to jump into some discussion today about healthcare production, cost, and supply. But before we jump into the supply side of the healthcare version, or at least the healthcare environment, I want to go back and spend just a few minutes. We've been talking about demand for medical care, demand for healthcare, demand for health. Most of that demand is driven by consumers. Consumers are trying to optimize or maximize utility. And utility, again, as we've talked about in the past, it goes back to your micro classes. It's satisfaction or benefit of consuming a good or service. So if you think about healthcare, that for the most part, individuals go to the doctor when they're not feeling well, when they think they're sick or they have an illness, or maybe they go for an annual visit, or maybe they go for some type of immunization, especially if you've got young kids, less than, say, 6 years old, you're taking them a lot to get immunizations. But again, it's the consumers that are driving that demand side of the healthcare environment. And on the demand side, as we talked about, it's, most people are born with a certain stock of health, or a certain level of well-being when it comes to their health. And if you continue to manage that health in a fairly prudent, approach, or a way that tries to expand or I guess ensures that you will live a long and healthy life, then you may not generate as a consumer that much demand for health or medical services or healthcare as you go along, until you get to be in what they call those senior years. And then when you get into those senior years, you're going to probably generate a lot of demand for healthcare goods and services. And whether you're talking about the demand for healthcare, whether you're talking about the supply of healthcare, it's all driven, and it goes back to I always call them the three pillars of economic thought. It goes back to looking at opportunity cost. It goes back to looking at self-interest and optimization, and it goes back to making decisions at the margin. Again, if you're a consumer, you're trying to maximize your utility, and you will continue to consume a good or service as long as that marginal benefit of consuming that good or service is greater than the cost of consuming that good or service. So then some people actually argue in healthcare that at some point it's a little difficult for individuals because they don't really know what the marginal cost is. The individuals a lot of times don't factor in. I mean, yeah, there's some explicit costs that they factor in. When I say an explicit cost, it's if you're an accountant, you're in working for a health plan, or if you're an accountant working for a provider group, you're looking at cost in which generates an invoice or which generates an outlay. But when you're looking at economic cost, and that's what consumers typically should be looking at, is you're also looking at not just the explicit cost, but the implicit cost too. Implicit cost is I've described in the past. Takes me 2.5, 3 hours, I don't know, to go see my primary care doc. And again, it's the wear and tear on the car, it's the cost of gasoline, it's parking once I get there, it's 2 to 3 hours out of my day that I'm never going to get back. And so a lot of individuals don't think about those implicit costs. All they're concentrating on when they go to the doctor is copay, coinsurance, deductible, what's it going to be out of pocket to go see that physician. And then are there going to be some other services that they have to purchase? Maybe they need an x-ray, maybe they need lab work, maybe they've got some pharmaceuticals or meds they have to go pick up. And so they tend to think about that they should be tying the explicit cost and the implicit cost together when they talk about going to the provider. So at that point, we're gonna, because most of what consumers do, and it's their desire, whether it's trying to maximize utility, or or just in general trying to feel better when they go to the doctor's office, there's also it's the law of demand. So it typically, and in most instances, as prices get lower and the demand curve slopes down, as prices get lower, individuals are going to increase their quantity demanded for those goods or services. And it's, to some extent, it works that way for healthcare. I'm not sure it's exactly that way, but for the most part, it works that way. So, and one of the other reasons that healthcare goods, the demand for healthcare goods and services, one other reason it's a downward sloping demand curve is because the substitution effect and the income effect of the decreasing prices. So decreasing prices, you tend to purchase more of it, but also as prices decrease, depending on what the percentage of your budget that is allocated to healthcare, as prices decrease. So let's say you go to a health plan that you've been paying a $25 copay, and all of a sudden now you're going to one that's a $10 copay, and it's going to cost you the same premium. So the prices of those services have decreased, and it might incentivize you to go seek more healthcare services. At the same time, it's giving you in that instance, another $15 in additional income that you can spend on doing something else. Go out to lunch, go to a movie. I don't know, that's about the only two things I can think of that you can get for $15. But again, it's that income and substitution effect that drives that negative sloping demand curve going down. And now we're going to turn around and we're going to talk about the supply side of it. So got the demand side and the consumers. Now we're going to talk about the supply side. And the supply side is driven by healthcare providers. It's driven by, hospitals. It's driven by urgent care, ambulatory surgery, pharmaceuticals. All of these types of, and I'll call them providers, just as a general term, all of these types of providers are driving the supply side of that function. And if you, again, that don't want to sound like I'm beating a dead horse, but so much of what we're talking about and when we're talking about health economics, or healthcare economics, when you're talking about it, it's all driven by the theory or the concepts that you learned in your microeconomics classes. And so it's not going to matter as we go through the discussion when we're talking about production and cost and supplies, it doesn't matter which side of that financial coin you end up working for if you decide to go into healthcare. It doesn't matter if you're on the health plans, on the payer, we'll call it the payer. It doesn't matter if you're on the payer side or you're on the provider side. It's going to be the same microeconomic factors that are going to drive the decision-making process on either side of that financial coin. And so hopefully this will give you some of those tools, again, you can put in that toolbox. And when you get out into the real world, if you decide to stay on the healthcare side, it should help you to be considered a valuable resource or a valuable asset to either the payer side or the provider side, which one you end up with. And so if you're talking about healthcare production, it goes back to the basics. They're talking about the factors of production. So, and most people talk about the factors. It's labor, it's capital stock, and when we say capital stock, not so much the financial capital of stocks and bonds and savings and pieces of paper. It's more capital stock in building, machinery, technological devices you have. That's more along the lines of capital stock. Then you've got natural resources. The gas, if the gas that maybe heats the office. It's the building that you either purchase or the building that you lease. Those are considered, those kind of fall into some of those natural resources. But one of the biggest natural resources that you have is not so much the building, but the land that building is erected upon. So, and if you think about, let's just think about Meharry Medical Center, just across the campus from Fisk. And if I don't have don't have a lot of great detail about the medical center, but it just appears to me it's probably somewhat constrained when it comes to additional land. I don't know whether they have the capability of expanding much, but they're going to be constrained by the natural resources, and natural resources in that case being land that the medical center is built on. And then you've also got not only the big three of those factors of production, you've also got technology. And when economists talk about technology, it's not so much the computer chips and in your iPhone or the computer you've got. That's more considered capital stock, or the iPad that they use, again, more capital stock. Technology to an economist it's the technology that drives the process. It's the technology that drives the production function. It's the technology that helps and we'll use the providers. It's the technology that helps the providers take inputs and turn inputs into outputs. And for most providers, outputs are office visits. Outputs are surgeries. Outputs, maybe if you're a pathologist, it's reading lab results. If you're a radiologist, it's reading radiology films or MRIs or CAT scans. So that's what they're talking about, technology. And then also tied into technology, it's entrepreneurship. Those individuals that can seek out opportunities to improve processes, seek out opportunities to generate additional profits, because I do somewhat care, but at the end of the day, if you ask a provider why they went into the medical profession, you may get a variety of answers. But at the end of the day, they went into the medical profession to generate profits. All factories, all firms, all entrepreneurs go into business, they generate output, and they generate output so they can maximize profits. Goes back to the self-interest, goes back to the optimization as far as one of the pillars of healthcare thought. So you've got these factors of production, and once the providers or the payers can grab their arms around these factors of production, especially on the provider side, then they have a decision to make. They have to decide what goods and services they're going to produce, how are they going to produce it, and the how is what's their production function going to look like. They're going to have to determine who do they produce it for or for whom. And then also they have to have the wherewithal to set some resources aside. They don't want to use it all up in the short run. They want to set some aside for the long run so they can expand and not only become more profitable, but stay profitable for a longer amount of time. And one thing, before we get too far along in this discussion, is we're going to talk about it, and you hear economists talk a lot about the short run or the long run. And I've had students before ask me, well, what's the short run? I said, I don't understand what the difference of short run and the long run is. From an economic perspective, or from the viewpoint of an economist, the short run is a period of time in which only one factor of production is allowed to vary and everything else is fixed. And typically in the short run, because it's the easiest to acquire and the easiest to some extent let go, it's labor. So typically when economists are doing their analytical work and they've got the model set up, and the model again is based on kind of a competitive marketplace, they are in the short run, they're allowing labor to vary, and they're holding fixed capital stock, which includes building, they're holding fixed the natural resources, and they're holding technology and entrepreneurship fixed. So that's a short run. Now, in the long run, all of the factors of production can vary because you're talking about a longer time period. In the long run, the healthcare provider is looking at, okay, what do I do? I'm doing really well in my business. Do I, bring on a partner? Do I expand, and we have, multiple offices scattered around Nashville. So they're looking at long range decisions, long run decisions. And by looking at those decisions, they are trying to determine how they're going to produce going forward. Because every provider has a production function, maybe an implicit production function, but everybody has one. Let's take my primary care doc. My primary care doc is in an office with, I don't know, 4 or 5 other primary care docs, and they have determined that their production function, they can take the inputs that they have and in the form of, capital stock, labor, natural resources, the technology process of how they bring patients in and, get them in, get them seen, get them out the door. They have that production function laid out in such a way that they think it is efficient and it's going to generate them the highest level of profit possible. And hospitals have production functions, ambulatory surgeries. Everybody has production functions. You have a production function. I have a production function, just in the way I do my daily activities. And if you go, so let's say you're one of those individuals that gets up every morning, you have to go to Starbucks to have a cup of coffee. You walk in the door at Starbucks, and there it is in front of you. There's the board up there that's got probably a bazillion different kinds of coffee on it, the different prices. They've got some little snacks and cakes and sandwiches and things. And so when you walk in the door, Starbucks has determined, at least and I'm not a coffee drinker, but I'll occasionally, take my wife into Starbucks, and we'll go in and you can look around. And as an economist, I guess I'm preoccupied with some of these things, but typically in Starbucks, I go in and their production function, they're taking their inputs of production and turning it into cups of coffee, cups of tea, hot chocolate, some snacks maybe. And so you go in and there's somebody working the cash register. You got somebody over here that's handling the microwave and taking care of the snacks. You've got 1, maybe 2 people that are kind of the baristas that are making the coffee and the tea and foaming the milk and all that stuff. And then sometimes you may have another individual that kind of comes out periodically, cleans up tables, calls out people's names that they're, food's ready, but they have developed their production function for that. The CEO at Meharry has a production function. Each one of his or her departments within the hospital has a production function. Radiology does, laboratory does, surgery does. If they've got, OBGYN services, they do. So each of those departments have a production function in which they're taking the inputs of production, running it through that production function, and generating lab results, generating radiology results, completing surgeries, delivering babies. And that is the core of like the healthcare production at that point. And if you have the notes that I've attached out there on Canvas, I'm going to kind of follow some of these notes down. And in the short run, so we talked about the short run. In the short run, firms have 2 decisions. They have a decision of what to produce and a decision of how much to charge. Now, in the healthcare environment, if you're a provider that has a lot of managed care agreements, you've already determined how much you can bill whatever you want to, but you're only going to make X number of dollars on a given service, depending on what your contract is with the health plan. And so as you're a provider, you may have some private health care, you may have some Medicare Advantage, you may have some Medicaid. Around Nashville, especially, you're fairly close to some military bases. You may have some TRICARE. You may have some VA business. You may have some private pay. And so you're going to get for a given service, and we'll take as an office visit, a 99213, that's your intermediate office visit. That's the CPT code for it. And so for that intermediate office visit, you're going to have a contract with each one of the health plans that you deal with. So if you've got contracts with a dozen health plans, you could have a dozen different prices for that one CPT code or that one office visit. If you deal with Medicare Advantage and Medicaid and TRICARE, in most instances, those negotiated rates are going to be lower than private healthcare rates are going to pay. So, and if you have private pay, you can pretty much negotiate whatever price you want on private pay. So you've got to decide what you're going to produce, and you've got to decide based on your contracts, not so much based on your contracts what to charge, but based on your contracts, how much of your service to allocate to different types of healthcare revenue streams. And again, I view, Medicaid as a revenue stream, Medicare Advantage a revenue stream, TRICARE, VA, private. I view those all as different revenue streams from a provider perspective, because they could be very different rates. And so as a provider, you need to, you're going to have to decide, well, do I even want to take Medicaid? Do I even want to, serve a geriatric population? And if I do, I'm only going to accept X number of patients into my practice. I'm going to only see X number of patients in my practice. So that's in your short run model of production. And in the short run, medical firms, at least in the model that we use as in economics, firms produce a single output, and typically it's two inputs, and it's typically either labor or capital, and labor is the one that typically varies, and capital is the one that is typically fixed. And the short run, the incentive to produce efficiently, because you have perfect information regarding service demand. As we've discussed in healthcare, I'm not sure there is such a thing as perfect information when it comes to healthcare. There's asymmetric information on both sides, from the consumer side and from the provider side. There's also asymmetric information when you start dealing with the payer. So I'm not sure that works. But in the short run, economists assume a competitive marketplace, and a competitive marketplace assumes perfect information. The production function, as I've said, transforms inputs into outputs. In the short run, the production function, its quantity, is a function of labor and capital. That's the typical production function. And different combination, efficiently maximizing output, subject to technology, education, training, entrepreneurship. Again, remember, a lot of this is fixed in the short run. So you've got the two main factors that you're thinking about as you're thinking about labor, which you can vary. You can hire, you can fire, you can lay people off, you can use a staffing firm that you can call over in the morning and say, hey, I need, 3, medical technologists. I mean, I need a PA to come over and work today. I need a surgery tech to come over and work today. So you can play around and vary that labor component. But in the short run, based on the model, capital is fixed. And then we get into an interesting concept where we're talking about, production, especially healthcare production, diminishing marginal returns. And what that means is output starts out increasing at an increasing rate, but eventually it shifts to increasing at a decreasing rate. It kind of hits, so it's going up at an increasing rate, kind of hits an inflection point, and it starts to flatten out a little. Output is still increasing, but it's not increasing at the speed that it was before. And it's because it's when we talk about diminishing marginal returns, we talk about it's the range over which an additional unit of a variable factor adds less to the total output than the previous unit. So if I think about going to my healthcare provider here in Atlanta, and I noticed a situation the last time I went. In the past, I'd gone in and course, they want everything done, using technology, and I've already signed in. I've already completed all the paperwork on the internet before I go, but I still get there and I have to give them a credit card for my copay, have to show them my driver's license, make sure they know it's me. Have to check in 15 minutes ahead of time, even though I know they're not going to see me on time anyway. But so I go in, I check in, I sit out in the waiting room with 15, 20 other people, and all of a sudden, somebody sticks head out the door, calls my name. I get up, I go in. The individual, I think she's like, some type of a tech, the medical tech or a some kind of a tech. So she's hopefully she knows how to read the scales and checks my height and puts the blood pressure cuff on my arm, takes my blood pressure, and they ask you that, to me, just probably one of the stupidest questions they can ever ask is, well, what's the reason for your visit today? Well, I'm not feeling good. That's why I'm here today. But anyway, so we sat there and we chat for a few minutes, and then all of a sudden she gets up and leaves, and she says, the PA will be in a few minutes. So, okay. A few minutes, a PA comes in, and you got their little laptop going, and they're keying stuff in on the laptop, and they're saying, these medications you're on, has anything changed? And, go through the same bunch of questions every time I go. And then, this individual jumps up and takes on and says, hey, physician will be in to see you in a few minutes. And I don't know, maybe 30 minutes later, the doctor comes strolling in, asks me the same question, well, why are you here today? Because I don't feel well. That's why I'm here today. And so we go through all of this, and I finally, he gives me a treatment plan, and I get some medications, and I'm going to go to the CVS, or I go to Costco now for my medications, but I'm going over to pick them up. And as I'm going down to get to the car, I'm thinking, well, the last time I was here, I saw the registration people. I saw the little tech, same little tech that took my blood pressure and everything, but that tech also asked me questions about my pharmaceuticals and how I was feeling. And then she got up and left and said the physician will see you in a minute. So they have added another individual. And so when you're talking about diminishing marginal returns, that's what you're talking about. Did my physician, because they added a PA in between the tech and seeing my physician, did it actually increase the output for their office? In other words, from my perspective, let's say they were seeing 3 patients an hour. Did it increase that output to 4 patients an hour? Or did it increase the output to 5 patients an hour? It didn't seem to go any faster for me when I was there, but why else would they have added an individual in between the tech and the physician, other than to think they could improve their production process and increase output? And so if you're a physician's office, you're looking at, as you add those individuals, you're looking at basically the marginal product of labor. Again, marginal decision rule. And the marginal product of labor is nothing more than the change in quantity. And for my primary care doc, it's going to be the change in the number of office visits per hour, the change in quantity divided by the change in labor. So if my physician is a profit maximizer, which to me, there's no doubt, he is, he's going to be looking at, did adding that PA into the production process, did it increase the number of office visits that I was able to generate in a given hour? And not only is he going to be looking at the marginal product of labor, he's going to be looking at the average product of labor. And the average product of labor is nothing more than the quantity divided by the number of FTEs. And that may be something as simple as, so let's say the physician works 8 hours. Let's say he normally gets, 3 patients an hour, so it's 24 hours and 24 patients in a day. By adding, so he starts looking at his office staff and dividing that office staff into the number of hours or the number of patients that he or if you know there's some females in the business too, so they're all looking at, by adding this office staff, how much is it, what's the average number of units that they see in a day per their given number of FTEs that they have in the office. So that's what they're starting to look at. And so when you're talking about increasing marginal returns, you're talking about quantities going up at an increasing rate. Again, it's the slope of that curve. And when you're talking about decreasing marginal returns, you're still going up in quantity, but you're not going up at the slope is not as steep. And so you're not adding to quantity at as the same rate that you were earlier. And then at some point, you're going to hit, you could, and most do, you hit and it starts going to negative marginal return. And that negative marginal return, quantity is actually going down. And a lot of times when you're starting to hit that negative marginal return, if you think of a doctor's office, they're only, you know, it's bricks and mortar, and there's only so many exam rooms, and there are only, you know, so many chairs back in the billing area, and there's only room for 2 individuals to register you in. So that's when we start talking about, you know, negative marginal return. You know, you can throw bodies, you can throw warm bodies at a production process, but at some point, you know, it goes from increasing to decreasing to negative if you're not careful. And with that, I think I'm going to pause, give everybody a chance to take a breather. And when we come back, we're going to talk for a few minutes about cost. See you in a minute.